Hello and welcome. This is going to be, it'll probably be an hour long lecture on cervical cancer. I made this lecture for the University of Michigan core didactics for the residents, and it got pulled into a case, so I wasn't able to give it. And so I promised that I would record it and post it for everyone to see. So I sprinkled in some jokes and just some random things in here. And the first thing that I wanted to go over is a little plug for Gyn-Onc. But why is Gyn-Onc the best? Number one, obviously the patients. And then number two, a lot of the things that we do are evidence-based. And I find that some other OBGYN specialties, they don't have as much evidence as we do. And so it's actually really fun to look at why we do what we do. We can say, we use this many cycles of carbotaxol because of this trial. It's really cool. And we can talk to our patients about it, why we do what we do. So I'm hoping that this lecture will go through and help you understand why we do what we do. A little bit of an overview of how we'll go through things. Actually, the cases are sprinkled throughout, so that's not true that there are no cases at the end. They're sprinkled throughout. Won't be touching on any pre-invasive disease, cancer in pregnancy, or rare histologies like neuroendocrine. A little trivia, where the word cervix comes from. It comes from the Latin word meaning neck. Cervical, cervix, all have to do with neck. So just to start with some basic stats for cervix cancer, it's the third most common GYN cancer diagnosis and cause of death of GYN cancer in the U.S. New cases, there's about a 7.7 per 100,000 women per year, and the death rate is 2.2 per 100,000. The lifetime risk of developing cervical cancer currently is 0.7%. And the relative 5-year survival is about 67.2%. And based on stage, you can see, a lot of the times we're asked, like, when patients are newly diagnosed, what's their relative 5-year survival, or they want to know their prognosis. And so we can say, we can lump it into, it's about a 70% 5-year survival, or you can break it down to stage, which may be good for people who are localized cancer, and you can say it's about 91%, or obviously worse for distant, which is closer to 18%. And this is just a look at, back in 1975, the incidence of cervix cancer was almost 14%, and the risk of death was 5.5%. And actually, my face is in the way of this other one. But the risk you can clearly see has gone down. The incidence has gone down. And I'm pretty sure that this is like 2.2 for the rate of death. And this arrow points to when the FDA first approved the HPV vaccine. So this and cervical cancer screening has led to a large downward trend in incidence and mortality of cervical cancer. This is the rate of new cases based on race and the rate of death per race. So new cases and then death. The highest incidence here you can see is the Hispanic population, and the highest rate of death is non-Hispanic Black patients. So we have a lot of work to do in these categories. Risk factors for cervix cancer. HPV-related risk factors is anything that will increase your exposure to HPV. So early onset of sexual activity, multiple sexual partners, a high-risk sexual partner, history of sexually transmitted infections. Also a history of VIN or vulvar cancer, especially HPV-related, obviously, and then immunosuppression. Some non-HPV-related risk factors are low socioeconomic status, OCP use, smoking, and then DES exposure for that clear cell adenocarcinoma. Okay, so shout out to Bill Nye. And going back to the basic science. So how does basic science behind HPV play a role in the treatment of cervix cancer? So why do we use cisplatin? Why radiation? How do these work? How do these work synergistically? And how does HPV play into this role? So we know that radiation induces high levels of DNA damage in tumor cells, which then promote apoptosis of the cell. And then the addition of cisplatin, okay, so here you can see radiation. The addition of cisplatin increases anti-tumor effects, and this has been shown to improve therapy outcomes in cervix cancer. So tumor cells respond to DNA damage by then trying to activate the DNA damage response in the cell cycle, and they'll try to repair the DNA damage. And so just a quick, rundown of that. RT-induced DNA damage, and then the addition of cisplatin creates anti-tumor effects, more DNA damage. And so what about HPV? So I will continue this photo on the next slide. And so before we talk about how HPV plays a role into this, I just want to talk about HPV oncoproteins because they are really important to this point. And so quiz yourself, what are the HPV oncoproteins? HPV E6 and E7. And so really important to know, HPV E6 degrades P53. And then if you follow this down, this will lose checkpoint 1. And so then you're completely reliant on checkpoint 2. And if you don't like this linear one, I have this circular one here, which in my mind is a little bit easier, I think, because we're used to this circle. And then HPV E7, this blocks retinoblastoma 1, and this also blocks G1. So HPV kind of hijacks this DNA response pathway to benefit itself, to get into the DNA and replicate like crazy. And if you remember, these checkpoints in the cell cycle will stop the process of cell division if they sense any kind of damage going on. So they sense this damage, they stop the cycle, they try to repair, but by blocking these, this leads to just continued DNA damage and then cell death. So the loss of P53 bypasses the G1 checkpoint, and then the loss of RB, or retinoblastoma 1, also bypasses this G1 checkpoint. So we're now completely reliant on this G2 checkpoint to repair the cell. We're here. And so, like we just mentioned, causing DNA damage, that's completely reliant on checkpoint 2. So you see here HPV E6, E7, here and here, will essentially block these pathways of repair, which obviously you can see the repairs here. And so that leaves this pathway only. Cisplatin will also kind of take this out, and as well as radiation, and then we have cell cycle arrest here. So the point is that we're exploiting these vulnerabilities that HPV is causing, which HPV thinks that that's its advantage, but really we're attacking them with cisplatin and radiation. So it's kind of like, I think this pathway is somewhat like ovarian cancer and PARPs and the BRCA HRD pathway. So really cool. Presentations and symptoms of cervix cancer, regular heavy vaginal bleeding, postcoital bleeding, abnormal vaginal discharge. If you have locally advanced disease, you can have some flank pain. If you have an obstructed ureter or lower extremity lymphedema, DVT, hematuria, rectal bleeding. And so the different histologies. I note on some of the slides that some of this information is from Prologue, so there's that. But squamous cell is obviously the most common histology. It is HPV mediated, 16 at 60% and 18 at 13%. And then adenocarcinoma is second most common at 25%. And other histologies, including neuroendocrine, small cell, rhabdomyosarcoma. Of note, I just want you to note here that HPV 16 is the most prevalent in adenocarcinoma, but HPV 18 is found more commonly with adenocarcinoma than squamous cell carcinoma. This is only 13%. And so methods of spread, direct extension, lymphatic, hematogenous. And of note, ovarian mets occur in 0.5% of squamous cell carcinomas and about 1.7% of adenocarcinomas. So this is important. A lot of our early cervix cancer patients are young. And so we do talk to them about ovarian preservation. And, we talk about the risks, and these are some good percentages to have in mind when we're talking to them and making that shared decision. Basic workup after a diagnosis, physical exam, so speculum, bimanual pelvic and rectovaginal exam. We are now using the FIGO 2018 staging, but the FIGO 2019 staging included different methods, including cysto, proctosigmoidoscopy, IV pyelogram, and barium studies that could clinically stage the patient. And now our 2018 staging includes cross-sectional imaging tools, so MRI, PET, CT. We typically use MRI to assess for local extent, like parametrial involvement. Sometimes it can give us tumor size. PET is the most sensitive for nodal mets and distant disease. And then CT is about 50% sensitive. So PET and MRI are your best go-to tools. This is a nice picture of the staging, the FIGO 2018 staging. So you have your stage 1 confined to the cervix, 1A, 1A2, 1B, and goes through the categories. Stage 2, beyond the cervix. But then stage 2A, limited to 2/3 of the vagina, no parametrial involvement, and then 2B, parametrial involvement, so down and then out. And then stage 3, either lower vagina, potentially causing hydronephrosis, or nodes. And then stage 4, extension beyond the true pelvis or mucosa of the bladder or rectum. So treatment overview. We won't be going over any natural cancer treatments, but we will be talking about the difference between fertility sparing and non-fertility sparing treatment. So case 1, you had a 31-year-old, she had a cone with a diagnosis of squamous cell carcinoma, and she does desire future fertility. So we actually have 3 different subsets of patients here with 3 different stages. So what is her stage and what are the next steps? So pause, give yourself a minute, try to come up with the next stage. So patient A is a stage 1A with LVSI, patient B, 1B1, patient C, 1A2 plus LVSI. And so before we get into the management, I just want to go over 2 quick things that will play into the management of early stage cervix cancer. And so a quick anatomy tutorial here is just looking at the parametrium. What is it? I think when I was an early resident, the parametrium was something made up that people just essentially made up, but it's a real thing. It's the fibrous fatty connective tissue that surrounds the cervix. It contains a uterine artery and superficial uterine vein. And this is a really nice picture here. I'll just talk about when we're doing a radical hysterectomy and trying to take the parametrium. What we do is that we get under this uterine artery and we ligate it, and then we keep a stitch here. We bring it up and we pull it over if we're trying to get this parametrial tissue. We pull it over here, we dissect out the ureter, which is also running through here, and we take all of this tissue here connected to the cervix. It's a nice kind of picture here. I can't tell if I'm in the way of this, but you can see this is all parametrium. This is a ureter here. And here's your uterine artery running through, and we take all of this tissue here. So keep that in mind when we're talking about doing a radical hysterectomy, because this is the tissue that we are taking when we talk about the parametria. And then the next important thing is lymphovascular space invasion. What is LVSI? Why do we care? Why do we talk about it all the time? So it's defined as the presence of tumor cells within endothelial line channels outside of the main tumor. And here is a picture here. All my pictures are from the internet, and I do not own any of them. And so why do we care? It's a high risk factor for regional lymph node mets. It is associated with local recurrence and even distant mets after surgical treatment for early stage cervical cancer. So when we see positive LVSI, say on our cone specimen, that in our minds already piques us to say, this is a higher risk patient or this is a higher risk specimen and we need more investigation. So we're thinking this, when we're going into a surgery, do we need to do a radical hysterectomy? Do we need to sample the lymph nodes? And when we see LVSI, we know that we need to have a higher suspicion for lymph node spread. And so that gets us into our NCCN guidelines. We would take those two things into account that we just learned, and we look at stage 1A with no LVSI. And so that points us right over here to a cone biopsy as long as there's negative margins. So you might be asking yourself, like, this is cervical cancer. You just talked to us about radical hysterectomies and lymph node dissections for the last 5 minutes. So why are we not doing those in this patient? Stage 1A1 with no LVSI has less than 1% risk of lymph node mets. And in pink, you'll see the parametrial involvement, and it has a negligible risk of parametrial involvement. So we actually, and this is based on previous data, and so we actually feel safe doing a cone biopsy in these fertility sparing patients. Let's jump down to stage 1A1, 1A2 with LVSI. We just talked about LVSI. These patients have up to 9% risk of lymph node mets, and they still have about a negligible risk of parametrial involvement. So a cone with negative margins plus a pelvic lymphadenectomy is one of the options here for these patients. Also, a radical trachelectomy could be considered plus a pelvic lymphadenectomy. So adding the lymphadenectomy due to the risk of lymph node mets and that points to why we're doing that here. And then we'll go down to our stage 1B1 and not meeting conservative surgery criteria, which we will talk about that soon, and your select 1B2s. And so they go straight to a radical trachelectomy plus minus lymphadenectomy. And the reasons why? These patients have a 15% risk of lymph node mets, so we're definitely going to sample the lymph nodes. And then they have an up to 6% risk of parametrial involvement. So they need to have a radical trachelectomy. We do need to get that parametrium to be sure that we don't see any spread there. And so I hope that you understand a little bit more why we do what we do from this this staging criteria. Briefly, radical trachelectomy, I don't have a lot of experience. I saw one when I was at Memorial Sloan Kettering, which was awesome, but I haven't seen any since. And so I don't really want to comment much on it. I'm not an expert on it. And so it is a reasonable fertility sparing treatment for 1A2, 1B1, select 1B2s for lesions that are less than 2 centimeters. And you can see here, I think I'm blocking one of the pictures, but you can definitely look it up, and I'm sure you can even find a YouTube video on it. Okay, let's jump to the non-fertility sparing treatment recommendations. So same patients here, same stages. And the question that has been being asked more frequently is, what is the clinical value of parametrial resection, or in other words, a radical surgery? And so we now have data, one prospective study, and then also an abstract from the SHAPE phase 3 randomized trial that answers that question. So the CONSERVE trial was a prospective multi-center study, and it evaluated conservative surgery in early stage cervix cancer. It was stage 1A2 and 1B1, and they had to meet the criteria here. This criteria is already in the NCCN guidelines. So no LVSI, negative cone margins, squamous cell or adenocarcinoma grade 1 or 2, tumor size less than 2 centimeters, depth of invasion less than 10 millimeters, and negative for any metastatic disease. We'll go to the next slide in 1 second, which shows kind of the schema. But a cervical cone was performed to determine eligibility, and 1 repeat cone was permitted. Women desiring fertility preservation underwent a second surgery with a lymph node assessment consisting of sentinel lymph node biopsy or full pelvic lymph node dissection. And those who did not desire fertility preservation underwent a simple hyst with a lymph node dissection. And you can see that algorithm here. So there were 100 patients. You can see the cohorts: cone followed by lymph node assessment for fertility preservation, cone followed by simple hist and lymph node assessment, and then an inadvertent simple hist followed by lymph node dissection. So positive lymph nodes were noted in 5% of patients. Residual disease after post-cone hist was noted in 1 of 40 patients, so that gives us an immediate failure rate of 2.5%. And then they follow these patients for up to 36 months, and 3 patients develop recurrent disease within 2 years of surgery, which is like a 3.5% risk of recurrence. And so now, due to the addition to the NCCN guidelines, we can counsel our patients on conservative surgery using this data. And the SHAPE abstract was presented at ASCO this year, and I am looking forward to the paper coming out. So stay tuned. And here is the non-fertility sparing algorithm here on NCCN. Okay, so next case, we have a 40-year-old with a newly diagnosed squamous cell carcinoma to a max depth of 9 millimeters, positive LVSI, she's healthy, and she does not desire future fertility. So what's her stage and what are the next steps? Pause here if you want to think about it. But she is a stage 1B1. She does not meet conserve surgery criteria. Why? Positive LVSI. Correct. And so we have 2 options, rad-hist and pelvic lymph nodes, or EBRT and plus or minus EBRT, brachytherapy, plus minus cisplatin. So how do you decide which one you're going to do? Primary radiation or surgery. The take-home point here is there's an increased morbidity with surgery plus radiation. And we know that from the trial from Landoni et al. So this is a trial in 1997. Landoni reported the equivalent 5-year overall survival and disease-free survival in a randomized trial comparing radical hysterectomy versus primary radiation in stages 1B to 2A cervix cancer. And there was no difference in overall survival or disease-free survival between the 2 methods. Morbidity was highest among the subset of patients who had radical surgery and then followed by adjuvant RT. So then this prompted 2 pivotal randomized trials, which we'll go over next, to clarify the role of post-op adjuvant RT. And so surgery is preferred for stages 1A1, 1A2, 1B1, 1B2, and select 2A. And why is surgery preferred? It removes the primary disease, it allows for surgical staging, there is an option for ovarian conservation, and it preserves sexual function. So when should you consider primary chemo-RT? Stages 1B3 to 4A. Also, you need to obviously take into consideration the likelihood of needing post-op radiation. So we'll go over the 2 trials, Sedlis and Peters. And then if due to medical comorbidities, the patient isn't a surgical candidate, we can consider primary chemo-RT. So I already alluded to this, but how do you know if someone needs post-op RT? Who is at risk? We have 2 great studies. GOG 92 Sedlis criteria. So this was a trial of 222 patients, and they needed to have at least 2 of 3 high intermediate risk factors. So that's in the table here, and that's based on LVSI, stromal invasion, and tumor size. So the arms of this trial were adjuvant radiotherapy versus observation. And if you met positive criteria, you had a 30% risk of recurrence, which is very high. And so you can see the recurrence-free survival here at 2 years, 88% versus 79%. There is a 47% risk reduction in recurrence in the adjuvant RT group. And so that just is the conclusion of the Sedlis trial, which basically says if you meet those criteria, you are recommended to have adjuvant RT. And so what's the other study? And that's Peters. And so this was a trial of 243 patients, stage 1A2, 1B, 2A. And they had a hist and they had at least 1 high-risk factors. And so I like to think of these as the P's: positive margins, parametria, pelvic lymph nodes, positive. The arms of this trial were adjuvant radiotherapy plus cis plus 5FU, every 21 days for 4 cycles versus adjuvant RT alone. So the one major difference here is obviously the different risk factors. These are high-risk patients. The other ones were intermediate high-risk patients, and the addition of cis. So you can see here with these curves that the overall survival at 4 years was 71% versus 81%, and 63% versus 80%. So these patients are recommended to get chemo RT. Hopefully you're still with me. And so back to this case. This patient will get a radical hysterectomy and hopefully sentinel lymph node mapping, which brings us to our early stage cervical trials. And so we'll quickly just go over mode of surgery, open or MIS, which I think that we all know that at this point. And then full versus sentinel lymph node dissection. This is a picture here of the SPY camera that we use in our open cases to do sentinel lymph nodes. It still comes up on a screen like this. It's just a little bit more logistically difficult because you're looking at the screen and then pointing the camera, looking at the screen, pointing the camera, but overall it does a great job. So this is, we won't really touch on radical hysterectomy here, but I'm hoping to do a full rad hist overview on YouTube soon, so stay tuned for that. But this is from NCCN and just comparison of hysterectomy types, notable for the differences between a modified radical hyst and a radical hyst. So open versus MIS. If you've done a rotation on gyn-onc, then you've heard of the LAC trial, but the laparoscopic approach is cervix cancer. And what it showed was that minimally invasive hysterectomies had higher rates of recurrence. The disease-free survival at 4.5 years was 86% versus 96.5% for open surgery. And so now for patients with stage 1A1 with LVSI to 1B1 cervix cancers, we are, we're doing open rad hysts, basically. This was also looked at by Alex Melamed, who used SEER and National Cancer Databases and showed inferior mortality rates with minimally invasive radical hysts. And then sentinel nodes in cervix cancer has been being studied. This is the technique from the NCCN guidelines, very similar to endometrial cancer, where you're injecting in usually 2 to 4 points, as you can see here in the cervix. And you're identifying the sentinel lymph nodes at the time of surgery with the fluorescent camera. The Cervical studies are currently looking at the utilization of sentinel lymph nodes in cervix cancer. So Cervical 1 was evaluating the diagnostic value of sentinel lymph node biopsy, and they showed no false negative cases. Cervical 2 was focused on the quality of life data and morbidity, and they showed reduced lymphedema, reduced surgical morbidity, and better quality of life. And Cervical 3 is currently running, and it will be looking at the 3-year disease-free survival and quality of life. So looking forward to seeing this, but sentinel lymph nodes are already in the NCCN guidelines, and we're really hopeful that this will show a positive result. Okay. On to locally advanced. So we have a 47-year-old patient referred after a biopsy showing invasive squamous cell carcinoma. Exam reveals a 5-centimeter cervical mass with parametrial involvement, and imaging confirms that she has stage 2B disease. So what is the next best step? And I'm just going to throw back to a couple slides ago. When to consider primary chemo RT, stage 1B3 to 4A. And so NCCN guidelines here, we had our patient who had imaging confirming stage 2B, and basically leads us to this category. And so I just wanted to briefly touch on the chemoradiation trials in cervix cancer, and our take-home note is by adding chemosensitization, you can reduce the risk of death by 30 to 50%. So there were 5 and 6 here, phase 3 randomized control trials of concurrent chemoradiation, and they demonstrated a reduction in the risk of recurrence, local and distant, by up to 50% in patients with locally advanced disease. And these trials were noteworthy, and the degree of benefit by each was remarkably similar. And the National Cancer Institute actually made a clinical announcement recommending the use of chemo-RT in these locally advanced patients. So we're not going to go over any of the cases here, but just this is very noteworthy and just points to the data as to why we use chemo-RT. Okay, on to advanced stage. We're getting there, guys. A 31-year-old comes in with vaginal discharge, a friable cervical mass with extension to the pelvic sidewalls, and a palpable supraclavicular lymph node. She has biopsies that are consistent with squamous cell carcinoma. You do a PET scan, and there's hypermetabolic disease, including multiple lung lesions. You already have your biopsy of the supraclavicular lymph node, and she's stage 4B disease. So what is the next step? You're exactly correct. Chemotherapy, systemic chemo. And so what chemotherapy do we use? Is there any evidence? Yes, of course there's evidence. So GOG 204, there's plenty of historical evidence that we're not going to go over, but I think that we'll just start with GOG 204, cisplatin and paclitaxel. So this trial, it wanted to evaluate the optimal cisplatin doublet in advanced or recurrent cervix cancer. So they looked at the groups here: cisplatin, paclitaxel, vinorelbine, gemcitabine, and topotecan with cisplatin. And they looked at survival as the primary endpoint. And this showed that none of the doublets were superior compared with cis-paclitaxel. There was no overall survival benefit when compared to cis-paclitaxel, but when they looked at the overall survival in cis-taxel, it was about 13 months compared to about 10 months in the other 3 arms. So it is worth considering in treatment planning and future clinical trial design, and why cis-taxel is what we use. Okay, so this is you and you're wondering, there are other agents, Caitlin, that we use. So where does that come from? And I'm really glad that you asked. And that is where GOG 240 comes in. So this was a phase 3 randomized study. It used 2 chemo backbones that you can see here, cis-taxol and then topotaxol. Then they took both of those and they added Bev to 2 other arms. These were persistent recurrent or stage 4B cervical cancer with the criteria here, and they were randomized into each of these. And I just wanted to make a plug for HPV basic science again, because the HPV inhibition of p53 actually increases VEGF. So there is some really, really nice data, basic science behind the use of VEGF inhibitors in cervix cancer, if you want to look into that on your own. And so here's the Kaplan-Meier curve showing the overall survival comparing chemo alone with chemo plus Bev. And this showed a 4-month longer overall survival. And so conclusions, they noted that topotaxel was not superior to cis-taxol. And when the 2 chemotherapy regimens were combined, the addition of Bev was associated with increased overall survival. Main toxicities, increased hypertension. So that, when we're counseling patients on on the use of Bev, we're talking about hypertension, VTEs, and fistulas. So usually less than a 3% risk of fistula, GI perv. Okay. Now we have a 67-year-old. She has a history of adenocarcinoma of the cervix, and she had a fall. She went to the ER, and she has lung mets on imaging. She had a biopsy, and they're consistent with recurrent cervix cancer. So based on the trials we just discussed, what would you recommend? Pause to think about it. And then, is there another test we can do to potentially add a different therapy to our regimen? And you're exactly correct. PD-L1. So Keynote 826 was a phase 3 double-blind randomized placebo-controlled trial. It added pembro to platinum-based chemotherapy and Bev. So basically our backbone from 240, and added pembrolizumab versus placebo every 3 weeks. And so what is PD-L1? PD-L1 is an inhibition pathway molecule expressed on the surface of tumor cells. Pembro binds to PD-1 on T cells, hopefully you can see here, and then T cell activity is suppressed along with the immune system. We use the combined positive score to assess for PD-L1 expression, and that can be found here. So that is the number of PD-L1 staining cells divided by the number of viable tumor cells times 100. And a CPS score of greater than 1% is used as a cutoff to add pembrolizumab as treatment in cervix cancer. And so in Keynote 826, they showed that PFS and OS were significantly longer in the pembro group than placebo in patients with a PD-L1 expression greater than 1. Okay, so say this patient, she got her systemic therapy with pembro. If she recurs again, are there any options? So just a note that you always want to look to clinical trial first. You always want to see if your patient is a candidate for a clinical trial before recommending, even second, third line things. So say we don't have an open clinical trial here for her. She can't travel anywhere. Is there anything else that we could recommend potentially in this picture that we have data for? Tisotumab vedotin. So we have phase 2 data for recurrent and metastatic cervix cancer with disease progression after chemo doublet and Bev. And tisotumab was given every 3 weeks until progression or toxicity. It was about 100 patients, and the objective response rate was 24%, with 7% complete responses and 17 partial responses. So the mechanism of action of tisotumab, which is hopefully demonstrated here, although small, is that the complex is, or TIVDAC consists of 2 parts. It consists of an antibody that attaches to tissue factor on the surface of cancer cells, and then a chemotherapy drug called monomethyl urstatin E, MMAE. And so this is taken up into the cell. It's broken down by proteolytic cleavage, and then it releases this MMAE, which then stops the cell cycle and kills the cell by apoptosis. And so most important for you all who will be seeing these patients in clinic, potentially in your chemo clinics, and what to ask these patients or what to look out for, the number one adverse effect is ocular AEs. So these patients, there's a really nice paper that I can attach here that goes over the management of these patients, but they all need baseline eye exams, no contacts, prophylactic steroids, vasoconstrictor eye drops, cold packs, lubricating eye drops. We have a whole protocol for them here, but always assessing how their eyes are doing and making sure that they are seeing an eye doctor regularly. Okay, this is our last case, and probably just going to fly through this portion because we could give a whole entire lecture on this next treatment, but this is a 62-year-old treated with chemo RT for stage 3B adenocarcinoma 2 years ago. She is coming in with vaginal bleeding, and you do a pelvic exam, and she has a 2-centimeter nodule on the cervix, no other abnormalities. Her biopsy is recurrent cervix cancer. And so what next? What workup would you do? Exactly a PET, and your next step would be to assess for an exent. So an exenterative procedure, or exenterative surgery, is the in-block removal of pelvic viscera. It encompasses the border of a radical hysterectomy, pelvic lymphadenectomy, removal of the bladder or rectum, or both, and reconstruction of the urinary and GI tract. So candidates for an exent have central pelvic recurrence, negative METs, negative margins, negative nodes. It's easier to actually say who's not a candidate for an exent. Any patients with distant METs, sidewall involvement, if a patient's unwilling to accept an ostomy, and the patient really has to have the ability to comprehend the counseling on the morbidity of this procedure, because we'll go over that on the next slide, but it's a very morbid procedure, and they need to be able to understand that. So risks of an exent, there's about a 3 to 5% chance of operative mortality. The morbidity is anywhere from 20 to 80%. There's a 50% risk of complications. There's up to 20% risk of reoperation. There's a 50% 5-year overall survival, and their length of stay in the hospital is anywhere from 10 to 20 days. On the right are some of the complications that can occur and things that we need to talk to our patients about who are going under these highly morbid procedures. So pre-op testing for our patient, we already got a PET to rule out any distant mets. An MRI can be helpful to delineate tissue planes, kind of for surgical planning, but also to rule out any invasion of the tumor. I would say counseling is probably, once you've done that, counseling is the most important part. And then it may take some multidisciplinary planning. You know, it's a morbid procedure. You definitely want anesthesia on board and up to date with what's going on. You may need urology if you don't do your own conduits, plastics for a flap if you don't do your own flaps, colorectal for the rectal portion if you don't do your own bowel surgeries. It's a very in-depth process. And then there are just a couple types of exents based on the lesion location. So you can do an anterior exent where the rectum is spared, posterior where you preserve the bladder or the urethra, or total where you're doing it all. So maybe in the future we'll do just a dedicated lecture on exents, but for now, that is all. Less than an hour is pretty good. I hope I didn't talk too fast. Here are some of my references. I would love your questions. I would love feedback. If you think that we skipped over something or you want more information, please let me know. I hope that you find this to be a helpful overview. Maybe, you know, you're not on ONC for a while and you come back and you can listen to this on double speed. Pretty decent, if I say so myself. So, well, I hope you enjoy. Thanks.